PrEP, the donors only left PrEP for expecting mothers, pregnant women who are going to give birth, and everybody else, you're on your own. So people who were high risk, people who were in discordant relationships and they want PrEP, it's a challenge now. We have injectable
how much is it
PrEP.
if you were to afford it?
It's expensive. It's probably 100,000 plus. So it's not, and the price keeps varying with different centers. PrEP as well, very very expensive. But then you'll see now that we have the injectable PrEP, the one that is taken once in 2 months, the one that you take once in 2 months. This is very good, but then there's no funding. It's very expensive.
Yes, it's very expensive.
This is the Policy Digest, a Center for Policy Analysis podcast that explores how African societies are governed and how people and their leaders are shaping the future of their communities. Through candid conversations and insightful analysis, we aim to provide a deeper understanding of the political, economic, and social landscape of Africa. So sit back, relax, and get ready to explore the diverse and dynamic world of African governance.
In the late 1990s, Uganda faced a tragic moment, which was the birth of the HIV pandemic. Now, I wasn't born by then, but I hear stories. I hear people saying it was not a good time. Now, at that time, the interim government had just taken over power and they couldn't take any risk in that. So they began a lot of programs from PSC to aggressive campaigns to ensure that they deal with the HIV pandemic. Over the years, a lot of progress has been made, but also a lot of bottlenecks have emerged along the way. Of course, Uganda has partners, it has friends. So along the way, a lot of support for that kind of work that deals with sexual reproductive work became outsourced to our friends, and I believe we're grateful for that. But that also created a unique problem, which is that anytime they sneeze, we get a court. Or anytime they say this should be the priority and we have a different priority, we then can't find our space. Which is why it's important to start having a conversation on owning the journey on health financing for sexual reproductive health work, specifically within the context of Uganda. And who better to do that than the people who are most affected? Who are the young people? Now, there's a movement which is in 15 countries called the United Movement, and I guess it's just about to speak to that, which is championing well-measured advocacy on the economic costs of us neglecting what is so vital for our country, which is health financing for vital work. And joining us today from the United Movement, the country representative for Uganda is Emojel Trevor. Trevor, you're most welcome to the Policy Digest podcast.
Thank you very much, Joseph. I'm very delighted to be here. It's a very wonderful space that welcomes ideas, and I believe we are going to have a very rich discussion today.
Thank you very much. Just speaking of ideas, I know the United Movement stands for some ideas. So could you start off by telling us about the United Movement, what they do, and what they don't do? Yes.
Okay, thank you. I will begin by introducing myself as Trevor Emojel, who works with AHF Uganda Cares as the youth coordinator. AHF is an HIV-focused organization. But for this discussion today, I am also part of United, the United Movement as the country representative. It's more of like a fellowship. It's more of a body that brings together youth-led organizations, youth-serving organizations into one space across 15 countries, like you said, and giving young people, mobilizing young people's voices for them to have increased participation in decision-making spaces. So ideally, you will find United in conferences, making policy papers, presenting to bodies like the AU, the EAC, very important spaces like that. I'll just give an example. There is this ongoing crisis we have of they are planning to sunset UNAIDS as of 2026 next year.
Yes.
And we all know that is premature. That is something we cannot accept because UNAIDS has played a very irreplaceable role when it comes to the leadership of the HIV response globally. So yesterday, with United, we were virtually attending the program coordinating board meeting and ensuring that in that space we were able to advocate for a rather phased approach of sunsetting UNAIDS rather than the very abrupt one. Yeah, and so in that space we were able to push.
Yes.
Yeah. So United is giving young people an opportunity to be in such spaces, but also empowering young people to understand that they have a very fundamental role to play when it comes to HIV and SRHR.
I get you. And I didn't want to start on a personal level, but it begs the question. Trevor, what was your spark? When did you say, let me commit part of my active life to this kind of work?
So for me, joining advocacy has been because of convictions on realizing that there are things that only we can take up, you know? I have watched so many spaces. I have been in so many rooms, and then you are the only young person. You are the only representative of your folk, you know? And so my conviction was, I can actually do this. I can speak to influence. I can speak to seats of power and share my voice as a young person and ensure that by having a seat at the table, I am representing whoever is not able to be there. So I have taken that upon myself, and I would say that I've been on numerous ones as of now, but I ensure that whenever I leave that room, I leave impact and I leave voices of people who would have wanted to be there but aren't.
Sure. Just to extrapolate that conversation, when is the first time you got to receive information on sexual reproductive health?
When I first got to receive information on sexual and reproductive health is about 15 years ago.
15 years ago?
Yes.
Okay.
It's about 15 years ago. I'm a bit fortunate because I've been kind of... I had the initiative, I had the drive, to look for this information. But unfortunately, there are many who do not have that, and they just end up colliding with it usually. But I was initiative driven. I had the interest, and I kind of felt I needed to be a part of this space, and especially about empowering others, sharing this information, and ensuring that whoever is listening to me is able to learn something.
Okay, Trevor, you've officially told us you had a certain level of privilege, even if it was just the initiative. But for the average teenager, for them, let's say on a scale of 1 to 10, how empowered do you think they are in terms of access to sexual reproductive health?
I would say right now that the average teenager has more communication channels for sexual and reproductive health than we had back then. But unfortunately, the average teenager is also bombarded with a lot of miscommunication at the same time. So they are battling with, who do I listen to? You know, and where do I get this information with? And that is why you will see reports telling us that we are still at 50%, roughly 50%, for young people in terms of information in regards to sexual and reproductive health, HIV. We are not even 3/4. We are still halfway. So I believe that we still have the mandate and the role to ensure that we educate. Because right now we're also seeing that people are downplaying, and the conversation is being deprioritized every day, and that is why we need to step in.
And for that 50%, in terms of, let's say, government and development partners, who is carrying the biggest responsibility at the moment for doing just that 50%?
If we look at our spending assessments, I would say that it is very evident that it is the development partners that are playing a very big role.
90%?
Actually, 80 to 90% when it comes to this. We can see government doing a bit of the bare minimum, but we are seeing that a lot of this is coming from the development partners. And that is why we're actually getting worried, because when they start pulling out, then we are actually left a little stranded, and we need to fill that gap urgently.
I totally understand you. And I just wanted to follow that nexus before we forward into the nuances on how we fix the gaps. Why do you think we find ourselves at this place where government doesn't feel like they need to invest as much? Is it because of the availability of the funding? Is this funding, are these funding gaps a good thing? Are they going to force the government to think and fill the gaps? I'm just want to explore that thought line.
When I look at our health financing landscape, for example, in Uganda, I would say that it is characterized by one, high donor support or dependency. We are seeing also a high out-of-pocket expenditure. That means more people are paying to actually access services,
healthcare
and services. And then we have government allocations, which are a bit less. And so we've had this complacency running over time because government has been having these partners. They've left the work to whoever is the partners, the development assistants. And that is where the gap has been. So now government is waking up to realize that, this is not sustainable and we actually need to step in. But we're also still seeing that they have not responded with the urgency we expected them to respond to these to these gaps.
Do you think, if hypothetically speaking, if the funding dried out, what would it look like for government? Would they push up the funding? Would they neglect the funding altogether? Because I've heard of narratives which seem to say that this looks like a development partners thing. It's not ours. So we're kind of just going with the flow. How do we create local ownership of the response, given that it is heavily subsidized by partners?
When you look at our reports, our annual performance reports, they tell us that roughly in the last 5 years, government has been giving 6%. The health budget has been receiving 6% of the overall budget, roughly. We are lucky that this year we actually celebrated that this year we had a historic high of 8%. But then would see that actually that 8% was also triggered by pressures of donors pulling out, triggered by pressures of stockouts. What next? And, we've been seeing a lot of action. We've seen integration happen the same year. We've seen a lot of, changes. So it feels like government is trying to regain control. But I would say that the pullout has also been premature in a way, because then it left our government systems, our health systems disruptive and not having the capacity, because we've been, they've been babysitting us the whole time. But government definitely has to step in because the risks are enormous. We cannot afford the consequences of not funding our health system, actually.
Yeah, Trevor, you've consistently said it was premature for funding to get withdrawn. I don't want to lose the point. I want to explore your thought line. Why do you think it was premature? It was their money. They could take it anytime. It's taxpayers' money for another country. Shouldn't you have seen this coming? What's your criticism for the idea that it came too soon?
Well, looking at why I would say it came too soon, one is that we've been having it in hindsight that funding is not sustainable. Actually, when you look at the data, it will show you that from around 2017 to date, it has been declining. So we've been seeing declining donor support over time, but then it has been a little bit phased and gradual.
All right.
And so we weren't ready. And I think our governments had taken up the complacency because they were seeing that at least for the next 5 years, we'll still be having resources. We're good. Yeah, but looking at what has happened now, especially for Uganda, 8% is way below the 15% allocation of the required allocation of the Abuja declaration, something that we needed to have stepped up on. And so we are seeing that governments are now making as rushed changes as they can to ensure that they fill the gap, which means they were actually not ready for this premature.
All right. I get the point. And I think I was just listening to a number of speeches of the Honorable Winnie Byanyima, especially when he comes to country and is speaking to partners. She kind of spoke about this for a long time. It's like she saw it coming. I remember when she attended the Kabaka cancer run.
Yeah.
I think there was another which had a theme around HIV. She was sort of speaking to like local ownership of health financing and how local philanthropy can sort of fill the gaps. But maybe if we had to just get to another nuance, what do you think are some of the missed opportunities that we're missing in the current health financing ecosystem when it comes to budgeting for the SRHR needs of young people?
Okay, so when we return the conversation to young people, I'm very passionate about that because I represent and I fall in the category. So for me, very importantly is even with the limited resources, our budgets are still not youth responsive. And what I mean by that is, yes, we have budgets, but we do not have specific as many indicators that are direct to young people. And that is a very huge challenge. We're living in a country where we have 42% of young people that are not in education, that are not in employment or any form of training. That is a very huge gap. You look at the unemployment rate of young people, it is higher than the national average. It is at 16%, while the other one is at actually around 12 or 13. And so that all speaks to the fact that we haven't considered as much the needs that these youth have. And speaking of health, it's actually more, it's terrible because when you look at the high out-of-pocket expenditure, meaning the young people, they are paying for services, you realize that this 42% can't actually pay for the services. You realize that they cannot actually afford. The 16% unemployed youth still cannot be able to finance or pay. So there's a lot of dependency on whoever is earning. And so we are creating some sort of poverty or gap, especially among our youth, which is affecting our economy generally. Yeah,
I get you. And recently, just here, we were speaking about the value of life and how health is important to the question of the value of life. If you take care of something, then it sort of communicates that you attach a value to it in that specific sense. For example, if a young girl in the Busoga does not have the health they need, I think that can inadvertently communicate how you value that specific life, because I think health is fundamental in that specific case. So you sort of speak about the budgets are not specifically responsive to young people. Have you done a study on the Ministry of Health budget? So for, say, the financial year that...
Well, I will look at largely the sexual and reproductive health indicators.
Okay.
you will see that not many of these indicators are actually tailored towards young people. Actually, for sexual and reproductive health, a lot of the indicators are on commodities, and that's fine. The sexual and reproductive health commodities.
Could you break that down?
Yeah, so the commodities, we have the family planning, the contraceptives.
Okay.
That's where we also get the condoms, etc. And so for us now, we are looking at child health, school health, adolescent health, some of those very important things, adolescent health. How much of our resources are going to adolescent health? Something that is very crucial. You know, when you look at the maternal mortality data, you will see that majority of these deaths are actually adolescent pregnancies, you know? And so how much are we devoting resources to supporting this? And so you see that even when you look at HIV, for example, you will see that at the heart of the new infections are young people, which is actually a very huge gap. So our issue is we can fix this with resources, you know, but if we have budgets that are very generic when it comes to the young people, then we must miss out the point. We know education, of course, is doing something. We know we have the economic PDMs, YLPs, but then there are still many gaps when it comes to fixing, especially on health.
I get you. We need to make it as granular to the extent that it meets the specific need. Mm-hmm. So I understand there's a budget process going on at the moment. Mm-hmm. Is there any work you're doing to ensure that I understand Parliament has started reconvening around issues of budget? So I imagine the budget framework paper is coming on board. Have you done any advocacy to ensure that the MIH budget, which probably is already in Ministry of Finance already going to Parliament, has those specifics?
Yes, that's a very important question. And I think with AHF, we are very big on health financing when it comes to our Parliament. And I think that they have been paying a little bit of an ear and listening in. And I think we appreciate the allocation that came in from last year. But our discussion is that it is not enough. So we're looking at this budget framework paper. But however, we're also looking at the utilization of the resources, because we may have good allocations, but poor utilization of the resources. So we are also paying an eye on the utilization.
And how they utilize?
Yes, of the resources. And so our advocacy is around ensuring that in each cycle, we are advocating for an increment, but also looking at the increment, what specifically are you increasing support on? Because you could say you're just increasing support. Yeah. So our areas are on SRHR commodities, very importantly. When you look at, for example, HIV prevention technologies, when the funders were here, they were actually the ones supporting. Now that they've pulled out, it's an enormous gap. Things like condoms, now we have the injectable PrEP, we have a lot of PrEP, but then because the funding has been coming from external sources, we are facing gaps now. So we're looking at the specifics. ARV treatment as well. Uganda is at around a 90% coverage for whoever is living with HIV to have the treatment. What about the 10%? That means we have people in this country who are not on the treatment. And so they're at risk of transmitting the virus. Yeah, because they're not on treatment. So those are some of the gaps that we want government to fill before we can look at the broader components of
I get you. Maybe to ensure we don't lose it. So your engagement with Parliament committees, with Ministry of Health, with partners that probably have how do I call it? Let's say broader influence on those that who can allocate the resources. How successful has that been in terms of the outcomes of the advocacy for reshaping those votes to meet the specifics?
Okay, so one, I would just share the approach that we are taking on. And one very important approach is to speak the language of the policymaker, and that is cost. And so what we've done is to inform them on the economic and social costs of maintaining the status quo. And that means not increasing support or investment. The general thing we are letting policymakers or whoever has the decision to increase allocations is that we risk higher health spending later by maintaining the status quo of lower resources now. We're risking that. I'll give you an example. UNAID released a cost of inaction report, and that report was on three things. It was on teenage pregnancy, GBV, and HIV. And so on teenage pregnancy, it is telling us that if we're not supporting the adolescent girls now and they're getting pregnant, one, that girl is going to drop out of school. And what that means is that you have compromised her opportunity to probably a higher income that she would have gained by being in school.
Member of society.
Yes, but then on the economic bit, most of the adolescent pregnancies can actually get complicated because of the biological risks, etc. So you're going to end up spending more on complicated
cost of healthcare. Yeah.
Yes, cost of healthcare. When you look at HIV, we've informed that every new HIV infection, when you look at the National AIDS Spending Assessment, it's telling us that government spends $190 on ARVs for one client per year. So that is around 600 to 700,000 shillings per year. So now we have, because the reports are telling us that we have 730 new infections per week. Those are more costs you're adding per week. Someone who's listening can do the math, and then put that at scale. Look at the already 1-point-something million people living with HIV. So by not investing in prevention now, by halting programs that are reducing the vulnerability of people to get more, by reducing the vulnerability of people to HIV, because that's our aim now, you are risking higher costs in the future. And that is our narrative. Yes.
Well, I think that's very, very spot on, Trevor, in terms of what specifically are we losing. And I know Trevor has ended the first segment on a very high note on giving us a lot of food for thought on this is pure math. Okay, that's too tough for those who used to fear math. This is pure data that is telling us in order for us to save the money we would rather lose in the future, we better spend in the right direction. In the second part of the podcast, we will try to customize the conversation. What specific youth pressure points can we have, even in the electoral cycle that we're in, even in regular accountability mechanisms that we can have to ensure that people respond to our needs?
The Center for Policy Analysis is an independent think tank shaping parliamentary democracy, governance, and public policy in Uganda and beyond. Our mission is to shape public policy and strengthen democratic governance by delivering high-quality research, fostering collaboration, and empowering citizens. Our vision is a democratic society with transparent, accountable, and responsive governance systems. What sets CEPA apart? A unique consortium model that integrates expertise from diverse partners for multidisciplinary approaches. We pioneer thought leadership, leveraging tools like artificial intelligence to enhance impact. Through collaborative advocacy, we empower stakeholders to engage with legislative processes, all while combining rigorous research with a deep understanding of Uganda's political economy. Our flagship initiatives include Parliament Watch Uganda, that bridges the gap between the citizens and Parliament, the Policy Digest podcast that explores politics and public affairs across Africa, and the CEPA Convo, our bi-monthly X-Space tackling key public issues. Our work spans parliamentary democracy, human rights, public health, road safety, climate justice, artificial intelligence, and more, including the Africa Regional Conference on Parliament and Legislation. Join CEPA in shaping policies, amplifying voices, and building a democratic future. Visit www.cepa.or.ug to learn more or follow us on social media. The Center for Policy Analysis, a leading public policy think tank.
So I've kind of been observing presidential elections, and there's no candidate speaking about the health of young people. I think most of it is on unemployment. Most of it is on other intersectionalities that may not specifically refer to young people. Still, if we're to refer back to the just concluded presidential election, one of the presidential candidates in America, Kamala Harris, had a sexual reproductive issue as a major political issue that they felt needed to be addressed on the front line of the political campaign. And even if you look at just African governments, it seems to not be a political priority to address specifically the health of young people. It looks, if I had to speak on the scale of priorities for political agendas for politicians, health is not major. So the question I want to ask Trevor is, and I know you belong to the broader African network that has a number of African youth fellows, how do we drive the issue of health to the political ballot or to mainstream political accountability culture? Because it seems like it is not.
Thank you very much. That's a very important question. And coming back to the discussion, for me, one major challenge I have seen, especially in the critical decision-making spaces we've been in, is that health is seen as consumptive. And I mean, they don't see it as something that is fundamentally contributing to the GDP or the growth of a country, which is a very wrong way to see it. And when I break down to young people, for a country that is as young as Uganda, with 73% of our population below the age of 30, it is even more critical that we speak health, because one, if we have a healthy young population, that we will have a strong workforce. We have a better future because many of them are going to be in school. So we have better prospects for our country because ideally they are the foundation and they are the ones coming forth. I don't know if that can take me straight to the priorities that young people have for health, but critically what I would say is back to sexual and reproductive health. It is important, first of all, that we prioritize the commodities. And by commodities, I mean the contract.
And I totally get you. And I just want to get to that. And we're going to get to that point. I just want to, money follows the politics. Yeah, so, advocacy or into advocacy spaces, which means I think getting the politics right is a prior to the health financing question. So I had wanted us to deal with the politics
first. Okay.
And I know we touched on the specifics in the first segment, but of course we're going to broaden it. In terms of just analyzing the political economy on how power influences what becomes a priority and what doesn't. I wanted to understand your political economy analysis on who has the power to make this happen, and how can young people contribute to those pressure points in shaping their perspective.
Thank you. So who has the power? I want first of all to believe that every Ugandan has the power, but who has the power on allocations? We're speaking about bodies like the parliament. And those are spaces where, they will sit and they discuss allocations. And oftentimes health is not seen as a major priority, like I said, because it's seen as consumptive and not very much as something that is growing the economy and the Ministry of Finance is going to say our economy is growing by this percentage.
Yeah, we invested this much, we got this much.
Yeah. But what they're not seeing, what the politics is not seeing, is that for those people to work, they have to be healthy. And that is why health as a sub-program under the Human Capital Development Program is actually very important, because it is a driver for development and for growth. And I think that is why that is what politicians like Kamala Harris were able to see. that for you to have a healthy population, a population that, has access to full health, a population that has control over their own bodies, a population that has control over their sexual and reproductive health, that is a productive population. Because when you see in the 90s when there were a lot of deaths, one of the reasons as to why actually the head of state was very concerned was because HIV was finishing his soldiers. And so you would see that. You would see...
He wouldn't let that happen.
He would not let that happen. And that is why health is very important.
Yes.
And that is why you see that the Uganda AIDS Commission is under the office of the president, because it is very, very important. Once poor health is eating up a country, the defense is going to be weakened, the workforce is going to be weakened. I hope I'm protected in this first for the discussion. Yeah. So you realize that
I've heard of that. So
that is the
you
extent.
Don't share the opinion yet.
That is the extent on to which health is important, and that is the narrative we're trying to sell to the decision makers. Yes,
I totally get your point, and I do follow Parliament quite regularly, and there's a lot of space in Parliament for advocacy on the pressure points. There's the order paper, there is other committees, there's the Prime Minister's question time. Where do you think the pressure points could be? Is it on the ballot in 2026? Is it the petitions? Should young people, like in the United Movement, like you're saying, pressure members of Parliament to ensure that almost every other week there's a sexual reproductive health issue coming up, such that the repetition of the issue forces government to respond to the issue? I just want to get your mind on what those pressure points could look like, since the politics are prior to the financing.
Indeed, political will and politics are very important for driving these issues, and we actually cannot avoid the politics. But I would first start by saying, as young people, I first of all feel we're a little bit disadvantaged in the Parliament. Why do I say that? For a country that has 72 to 73% of its population under 30, you will correct me, but we see around 12% of our members of Parliament under the age of 35.
They are a pocket. I'm going to try and get that.
Yeah. So you see that already it's the older guys deciding these things. So already you start the match with 2-0 because the likelihood that they are going to front your issue first is very low. Okay?
They may not also understand it.
They do not really understand these Gen Zs. They are calling us their grandchildren, and so you see that challenge that we have. But then when it comes to health, there are two specific committees that actually on our side. We have the Health Committee, Parliament, and then we have the HIV.
Before we lose it, do you think that's the problem? That our issues are fronted by people who may understand but not grasp the full context?
I think that is a very big problem, because even in management, when you have someone that does not fully relate with what you're going through, and that is my actually very big concern, because you'll see averagely it's 40, 50 in Parliament.
I just have the data here. This is a Parliament Watch, a fact sheet. The mean age of parliamentarians is 46.8 years. The youngest MP has 24 years. The oldest has 82. Which means the average is at 82. Between 24 and 28, there are 8 MPs, that's 1.5%. 29 to 33, that's 31 MPs, that makes them 39. 34 to 38, let's say they're still youthful, 12.3%. So in short, below 33 to 24, you're looking at less than 10%.
Exactly.
And even much lower if you get into the
exactly.
nuances,
So
yes.
with 12%, and legislation, I believe, is also a lot about numbers. And so we are losing largely when it comes to numbers. And also sometimes, I think for the youth MPs that we send, I'll not get there, but
I see.
it's important for us to note that is one of the concerns. But our narrative is that we can still make progress by having a roundtable discussion and pushing, especially for health when we get to committees like the health committee. And then the HIV committee. They have been receptive towards us, but then you realize that it has to be the whole house to make these decisions. But even when you get to this,
just auditing the health committee itself, we featured on the health committee. Yeah, you could tell. These are people in their 40s, 60s, 70s.
Yeah.
I know they could, but I don't know the extent to which they can understand.
And then, even in our experience, when we attend these committees, they have very less members, meaning the interest is low as compared to the others. So you'll see that people are more interested in probably the finance committee or probably the defense. You'll see more people there. Like, for example, when we attend the budget committee meetings, they're very well attended. So I'm seeing that even for our politicians, it is important that we prioritize and look at health. And you see, it's even worse among men, because that's another narrative that we're bringing up, because we're seeing even in the different health spaces, men are increasingly marginalized. In HIV, the mortality rate among men is extremely high.
But not so reported as much as the other gender.
Yeah. Not so many men are coming for testing, because men say, I am a man and I will only go to the hospital when I'm on a bed, or I am finished and I can't go to work. And so that, for me, it's all about the mindset with which we look at health. Health is looked at something as for women and children, something that is not as important as probably investment and something would be. But at the end of the day, health is wealth. Without your body.
I totally get you. And I know, Trevor, you said you have been in spaces where you're the only young person in the room. Have you ever got the impression that this is like just a diversity quota, but this is as much token as tokenism can get?
It is as much tokenistic as it can get, but you see, tokenism also depends on who is in the room. So you ensure that as Joseph, as Trevor, you make sure that you
whoever is a token
you make sure
be able to
because oftentimes
bend the narrative.
Oftentimes they will invite a young person knowing they're not really going to understand what we're talking about, and so we just want this to tick the books, and for the photographs and the group photos that we had a young person. But for you ensure that your point is delivered home and you try to follow through, befriend these guys. Sometimes it's also about the personal relationships you create.
Absolutely, yeah.
So then you get to push for things beyond the round table. Sometimes these things happen on a coffee table. Or,
just one, I imagine like a budget framework paper, because it's normally a consolidated budget framework paper. Even if it's just for the ministry, just like one young person in the room can make a difference, however small, and perhaps that's why it's important to share information of this specific nature, maybe just to get to the specifics. And I know people who would get interested in this kind of work, maybe that one person who will one day be Minister of Health or work in the context where health financing is being discussed, and maybe they will understand that we need to segment these priorities. So looking at the current budget, what should be the top youth health financing priorities if we're serious about reducing the new HIV infections and strengthening the SRHR response among young people?
Thank you. So within United and with AHF, for us, the key priorities to begin with for me are the sexual and reproductive health commodities, the family planning commodities, the contraceptives. We need to have those things, and I think procurement of those things has to be prioritized. We also need to prioritize youth-friendly service delivery. We're losing out on the youth-friendly spaces these days. They are getting how can I say, transitioned and being used for something else, especially with integration that's set in this year. We've seen youth spaces getting repurposed and taken away. And this is what happens with young people. Young people are not always comfortable getting mixed up with the older populations. And so without those spaces, people are not coming to health facilities anymore. Young people are not seeking information anymore. So it is important that we return investment. And you see most of these spaces were funded by the external parties, the donors, but also the community prevention interventions, the outreaches, a lot of these things. Young people, it is important to find them where they are. And these programs are working so well because you'd go, you'd have your camp, you'd bring the young people from where they are, they get tested, they get services. But now the priority is treatment. We no longer have the high-risk young people being reached out to, which is a very big gap, you know. Another very important thing for us beyond the prevention is generally the capacity building of health workers across. Health workers have contributed to young people fleeing facilities. Because I will come to you, Joseph, and I will ask for a condom, and they will say, I pity your mother and father. you know, they use those words that stigmatize you, and
you will never go back.
You never go back. Mm-hmm. You know, someone has come probably for testing, for contraceptive, and then there's a lot of stigmatization. So for us, even before we have the youth, because we also lost out on the peer leaders that were there, they also funded externally. We need even these ones, their capacity to be built so that we can have reduction in that stigma and discrimination that is driving young people away from facilities.
And I think that's quite important, but especially in the youth-friendly services. You spoke of them being integrated back into the system. Could you expand that thought line and how big of a problem that is for a country that is very youth-centric? Yeah.
For a country that is very youth-centric like Uganda, it's a gap in many facilities. One, I will start with directly for the young people living with HIV. We've seen that because you're bringing them together, let's say it's a main hospital. My uncle goes there. My auntie goes there.
Mm-hmm. You know,
my partner, everyone is going to say that I am living with HIV. I don't want to be seen. Mm-hmm. Yes. Mm-hmm. So because of that, they are being driven away. They just don't want to go there. Yeah. Another thing is because of that, we've seen a lot of long waiting times at facilities. So let's say Trevor has come from 2 districts away. I've come today. I've come for my medication. I come here. There's a very long line. There's so many people because now everyone is in one place. I'm not going to get served on that day. They tell me, come back the next day. I don't have transport.
You can't remain there.
I can't remain here. So I will go home and I will never come back. And I don't have access to any other facility. But another important thing is now for the negatives, for you know, the sex workers and etc., they now can't come. Because for them, the stigma, it's gone.
Much, yeah.
And some of these people having heterosexual relationships and then they're passing on the virus and then it's spreading. And so we're seeing this whole thing. And that's why the youth spaces were important, because we had that privacy, that confidentiality that was helping young people, you know, access
the help.
Yeah.
The help that they need. And you spoke about like commodities. Have you studied the extent to which the donor cuts have affected the availability of commodities that support the response?
Yes. For example, PrEP, the donors only left PrEP for expecting mothers, pregnant women who are going to give birth, and everybody else, you're on your own. So people who were high risk, people who were in discordant relationships and they want PrEP, it's a challenge now. We have injectable
how much is it
PrEP.
If you were to afford it?
it's expensive. It's probably 100,000 plus. So it's not, and the price keeps varying with different centers. PEP as well, very, very expensive. But then you'll see now that we have the injectable PrEP, the one that is taken once in 2 months, the one that you take once in 2 months. This is very good, but then there's no funding. It's very expensive.
Yes, it's very expensive. You had highlighted earlier on that government or partners were spending about $190 US. That's about 600,000 on health in a year.
On one person.
Just one person.
That's on one person. Yes.
And yeah, speaking of affordability, that's a huge question, and perhaps
and that is with HIV, even the drugs are different. That is first line drugs. So first line drugs, the least expensive. So we have the ones that are more expensive. We have people on second line, on third line drugs. So meaning it goes to about 800, 900,000, for example, third line drugs. And so we have those cases as well. So the cost is actually bigger when we look at, the numbers.
I get you. And I love that the conversation is coming to this point on cost, even as we wrap this up, because the last question, I'm going to get into the pragmatic aspects. Recently I was studying the National Development Plan, has been adopted by Parliament and Gov by extension. It said at one point that a child who lives in Uganda just achieves 0.38% of the potential. And I don't know what that looks like. The intersection between good health, education, generally human capital indices on how that potential turns up, and with more developed countries having higher indices and therefore more productive citizens, and therefore being able to tap into the benefits of investing in healthcare. So maybe just to close it, what financing innovations or new funding models could Uganda adopt to ensure we have a sustainable youth-responsive HIV and SRHR programs, especially in the face of shrinking donor support?
So I think this has been a very rich discussion, and I really hope that as many of our key people get to listen to this discussion, because I want to appreciate CEPA for a very, very rich space like this, but also United AHF for the opportunity to have this discussion. So for me, first of all, and this is not new, please let us increase our allocations for the domestic resources. We have the 8%, that was a historic high, but I think we need to get to as 12%. We need to get to 12%. It's very important that we raise to that and fund specifics. We need to also discuss what are we increasing support on, because generally the population is increasing, and so you'll have to increase the health expenditure. But however, what are the specifics that we are funding? So for us, meeting the 15% Abuja declaration target is very important, especially in phases. And then secondly, there are programs that donors are taking in, but for us, we are asking for where the donor is pulling out. How do we have donor domestic support? How do we have the both of them working together to fund something? Instead of the donor saying, I'm pulling out 100%, they are contributing something, and then government is contributing something. And I'm speaking right now for specifics of young people interventions, because you have a lot of high impact programs that have been running in the HIV space. But because the donor is pulling out, we are seeking government's involvement and how that synergy can help sustain those interventions. But there's also another very important funding strategy in HIV known as the HIV mainstreaming strategy. And this is where ministries, departments and agencies are mandated to allocate 0.1% of their budgets, all ministries, departments and agencies, to funding HIV interventions. Uganda AIDS Commission was able to collect 61 billion last year from that support. And so for us, but when you look at the data further, you will see that not every MDA is actually contributing.
Is
meeting
the end of the bargain.
Yeah. So for us, ours is, can we increase supervision over that collection, that those allocations, and ensure that across the board, every MDA is contributing? 61 billion may look like a little, but it's something.
Yeah, it's progress.
It's
not
progress.
Zero. It's not zero.
Yeah, it's progress, but also the utilization is very important. And then for me, another thing is a government is still struggling with tracking off budget support, especially from donors and partners. I think that is also one thing. There is a report that was released by Ministry of Health that said over 30% of development assistance is off budget support, and government doesn't get to lay their hands to lay their hands on these resources. And so what we're asking government is, how do you track these resources and ensure that a lot of it is not just going to salaries, but is actually going to the work?
Very, very important. Going in the right hand. Or even gov money itself. It's right. It's going in the right place.
It's going in the right place. So ensuring that we utilize these resources also meaningfully. You guide the donor. I know the conversation looks to be a little bit controlled, but you guide them. This is where our need is. You started the conversation by saying when they sneeze, we actually catch a cold. But how do we have a balanced conversation on, please support this? This is where our gap is.
Prevent duplication.
Yeah.
Donors doing the same thing.
Yeah.
Rather than aggregating the response and being more effective. The basket has
exactly
has
and
shrunk, yes.
Yeah, exactly. And that is why it is important for government to actually track off budget support. And then we also have something that the Uganda AIDS Commission tried last year. They started it. It is integrating HIV programming into these programs like PDM, Emyoga. Actually, they made attempts with PDM, I think, under the third pillar of mindset change and community mobilization. And they've seen working with them is another creative way of pooling resources.
Yeah, integrating them into regular programming.
Yes, integrating HIV into regular programming. So for us, our narrative now is, how do we get some resources? How do we have a conversation on increased support from those areas and see, more support coming in, because it's actually a good window. So looking at all those strategies, I think they would help us for now to increase, but very importantly, knowing that domestic financing is actually the engine to sustainability, and having government contribute resources is the most sure way that we are going to
get out of this.
To get out of this. Yeah.
This will be the last, Trevor.
Yeah.
The UNAIDS has raised issues around the cost of medicine, around the global capitalism empire, benefiting from very needed healthcare. Do you think there's a specific aspect of domestication of our response that deals with funding local research, local production of there could be either generic drugs or there could be specifics? How do we drop it from 190 to say 100 or 80 with the local research? And maybe could touch base on that as we close the conversation.
That's a very, very important question, and I'm very glad that it has come up, because one of the biggest issues that we're having as Africa is that we're not locally manufacturing our drugs. And so they are being sold to us very expensively. That's a very huge challenge. But also for the big pharmaceutical companies that are making these drugs, they're not releasing the patents. They're not making it easy for other people to actually make these drugs. So they are holding their patent rights. Yeah. So one of the advocacy points that we have that UNAIDS is actually fronting is for these companies to release and give these patent rights to other companies to make these drugs locally. But another very important point there is for African countries to consider local manufacturing. For us here to empower quality chemicals, for example,
to produce
maybe
half the price.
Exactly, and
a quarter the price. Yeah.
It would come down to probably $70 or $80 per person, and so that is very important. UNAIDS has a target to meet only to have 200,000 infections new infections as of 2030 globally. And currently we are at 1.3 million new infections globally. So maybe my question to the viewers is, are we on track to end AIDS by 2030? That is something that you need to think about critically.
Potentially being sunset within a year.
Exactly.
I agree with you, Trevor. I think this conversation has touched on critical points of the health financing question in terms of sexual reproductive work. And I hope you're a viewer, you've listened in terms of how do we get the cost of just the overall response from $190 per year, maybe to 80 or 40? How do we consider local manufacturing? How do we ensure Parliament and our leaders are responsive to the needs of young people, but specifically to the specifics that matter under the docus that Trevor Emojel has articulated? This conversation is far from an end. It's a beginning of a nationwide campaign to hold our leaders to account, to ensure that our health as young people is prioritized. Thank you for listening to the Policy Digest podcast, the Center for Policy Analysis podcast that is profiling African ideas and people that are shaping the future of their communities. Subscribe to all our platforms on YouTube and Podbean.